And today I'm going to talk about building a machine learning healthcare system. And I have the title in this way because when I'm talking to a medical audience, I de-emphasize the machine. And if I'm talking to an engineering audience, I can emphasize the machine, and I don't have to change my title slide ever. So that's a useful property to have. So this is my shock and awe slide. Something will show up in a second. No matter where you look, I mean, you'll see some version of problems in the healthcare system that form numbers to this effect. $3.5 trillion, give or take a few billion, and then lots of it being wasted. In this particular example by Stephen Brill in the Time magazine, there was a 36,000-word essay, probably the largest ever published in the Time magazine, where they estimated that about a third of healthcare dollars are wasted for numerous reasons. If you dig into those reasons, it boils down to this. We do a lot without knowing what works, at the scientific level, at the medical level, at the practice level. And whenever you have this situation, it does help to look at data to figure out what works. And that's where the learning health system and precision medicine and pick your favorite buzzword, the bottom line is that let's look at stuff that we're already sitting on and figure out what works. Other than healthcare, I don't know of any other industry that does not use the data of its consumers or customers to make a better experience for the next person who walks in the door. Travel agents are more sophisticated than that. Dentists, even pet doctors, veterinarians, more effective at using prior data than the healthcare system. Okay, so what do we do about this? You've probably also seen some version of what I'm going to show you here. On precision medicine, I would like to sort of stress two things. That yes, there's this problem and there's talk about precision medicine, but if you look at popular media, the press, it's all about precision in what I call the science of medicine. Let's measure the genome, the microbiome, the metabolome, proteome, whatever other ohm you can come up with. So a zillion variables in one person and figure out what to do. That's the precision medicine initiative, lots of press around it, 1 million people, the White House is pushing it and so on. And then there's precision in the practice of medicine, which is let's look at some data on millions of people to make better decision for the next person. The precision in the practice of medicine pretty much gets no press, but it has 10x the funding. So I'm sure people in this room, some of you have heard about PCORI, the Patient-Centered Outcomes Research Institute. It has 10x funding than the Precision Medicine Initiative. But in the press, you only hear about the Precision Medicine Initiative. And then when you start getting into the data, there will always be talk about big data, velocity, veracity, whatever. There are 5 V's and stuff. But I encourage you to think about these 3 axes. Think about people. They're not patients till they get sick. Think about features, which will be the columns in what's going to show up. And then we have them over time. So this is healthcare data. You have it on millions of people, thousands of features, drugs, diseases, procedures, devices. There's only about 4,600 FDA-approved molecules, so that's the finite universe of drugs. It is not, unmeasurable. Yes, there's lots of diseases, but there's about 8,000 ICD-9 codes that get routinely used, and 15,000 total. So it's a large number, but it's finite. Same thing for devices, procedures, and so on. And then we measure these things over time. Let's say we know somebody got a drug, let's put a 1. If we know for sure they didn't, let's have a -1. And if we don't know, put a 0. The -1, this negation, is something very peculiar to medicine. Very few other domains will have a data matrix where there is an explicit asserted negation saying no hypertension. You don't see that in most other fields. And then, of course, it's not nice and cleanly sampled like I show in this cartoon. People come to the doctor when they choose to or when they can or when they have to. So it's pretty asynchronously sampled and very sparse. Just to give you a sense for how sparse, if I create this matrix for about a 1.5 million patients worth of data at Stanford, and I fully materialize it with all the zeros in it, it'll be 378 terabytes. But if I only store the 1s and the -1s in a sparse matrix, in a compressed form, it's like 2.4 gigabytes. So just to give a sense, for big data in healthcare isn't really big. You can actually push it in memory on your phone. So if that's 1.5 to 2 million people, if I want to go to 20 million people, that's 30 gigs. If I want to go to the whole country, I could still push it in memory on a $20,000 machine. Okay. Then there's claims, which has been the fuel for most health policy analyses to date. You get it for a longer duration. Again, millions of individuals, hundreds of columns. And the nice thing about claims data is that it can be bought. You can buy data on 90 million people just by writing a check. A lot of people usually don't appreciate this fact, and you go begging to a hospital for data. Waste of time. Depending on what you want to do, just write a check and get it. And then there's quantified self. These are the new kinds of data coming around, how much you walk, how much you eat, how much you pee, stuff like that. Typically, you don't get it longitudinal too much, maybe 1 or 2 years, maybe 3 years if you're lucky. Here, the bigger problem is feature engineering. Because, what's a step? Some of you might be wearing Fitbits or Apple Watches, and if you wear 2 of them, at the end of the day, you get 2 different step counts. There's no way you walk 2 different steps, numbers of steps. And so the joke I often say is that inter-device variability of these things is higher than inter-mouse variability if you're a genomic scientist. So, you have to take that with a grain of salt. And then there's the genomics and the proteomics and the metabolomics, where you have millions of variables or features and a few 100,000 samples if you're lucky. If you want the whole genome sequence, maybe 20,000 people today that you could get whole genome sequence on if you knew a lot of connected people. So I encourage you to think about what I call the NP ratio, N being the rows, P being the features. Depending on the NP ratio, there's different things you do with the data. There's different math you bring to bear. There's different ways you think about storage, retrieval, analysis, and mining. And the typical hoopla around big data mixes this kind of big data with this kind of big data, and usually ends up in utter confusion, including on Stanford campus. Okay, so it's, we're no exception. Okay, so that's sort of the backdrop I wanted to provide. In my group, I deal with the EHR side of things. We dabble a little bit here and there, occasionally with looking at some genetic data, but the majority of it is electronic health records, reports made to the FDA, some clinical trial data, data from health forums about where patients talk about their issues, consumer search logs. These are via collaborations. We don't have, actually the US ones are collaborations. The non-US ones, we can actually get them on our server. We have physician search logs from search engines like UpToDate, and then, of course, the free stuff on Medline and so on. And with these data sets, we do 3 buckets of projects. We ask and answer clinical questions. That's a very med school thing to do, because if you don't do that, you don't get promoted in a medical school. Then we try to ask questions that a doctor wouldn't ask. What's the normal hemoglobin for a 39-year-old Indian? We have no idea. But we can learn that from the data. What's normal potassium for a 55-year-old Vietnamese woman? No one ever collected that. It might be a shock that it's only about 25 or maybe 40 laboratory tests for which the normal range is actually learned from measuring that metabolite in actual normal people, healthy individuals. The rest, next time you get a laboratory test, just call the lab or the doctor and say, where did you get that last column, and see how far you get. And then the third bucket is predictive modeling, where the idea is to, hopefully, predict something in the future. So who is going to be expensive next year? Who is going to have a delayed healing wound? A lot of predictive modeling in healthcare is just classification masquerading as prediction. True prediction is I tell you tomorrow's temperature, not I look at yesterday's data and classify it saying it was a hot day or a cold day. Okay. So I'll give you a few examples of each of these 3 buckets, and this is where I can throttle the talk to be 20 minutes to 45 minutes, depending on how deep we want to get into the various examples. So I'll start with a simple one. So for me, this particular paper about evidence-based medicine in the EHR is what started this journey. I wasn't involved with that. This paper got published when I joined the faculty. Jennifer Frankowich, the first author, was tasked with having to treat a 13-year-old female with systemic lupus erythematosus. How many of you have heard lupus or SLE before? Okay, it's typically a disease of middle-aged women. And Jennifer asked a few experts on how to treat this condition in a 13-year-old female. Menstruating female, you don't want to be giving anticoagulant therapy because you could bleed somebody to death. There's nothing in the textbooks on how to manage such a case. So she did something which was considered shocking in 2010. She queried our clinical data warehouse, which is supposed to be for research. And she found that the hospital had seen 98 patients. And in these 98 patients, 10 of them, and she's using these three words, thrombus, thrombosis, blood clot, 10 of them had the things she was worried about. And then she's looking for these risk factors, proteinuria, having pancreatitis, having antiphospholipid antibodies positive. She's using a surrogate feature, aspirin, using her knowledge of medicine that you only give aspirin to a kid if they're positive for this test. So it's a highly correlated surrogate. And then doing some division and then getting risk estimates. So this got them, Chris Longhurst, who's a good friend of mine, and Jennifer, into a lot of trouble with pretty much everybody you could get into trouble with, because IRB, compliance, legal, privacy, the CEOs, whoever. In 24 hours, everybody thought about this and said, this is what Stanford should be doing. Like, what else would you do? If you don't know how to treat an individual and your hospital has seen 98 people, why wouldn't you want to use that information? And so we said, all right, what about we try building a system where we can do this in a more systematic way? So we built infrastructure, and I call it infrastructure because it can include grad students and a coffee, to create this data matrix for data that we have at Stanford. And I'll walk you through the main components in a minute. So once we had this, again collaborating with Jennifer, we asked and answered a new question. So kids with juvenile idiopathic arthritis are at risk for this thing called chronic uveitis, which is an inflammation in the eye, in the portion behind your lens. And the current protocol says these kids have to be seen every 6 months by an eye doctor. And you take them once, and if you have kids, you go twice, 3 times. If the kid is fine, nobody shows up the 3rd or the 4th time. And so a parent of a child with juvenile arthritis posed a question to Jennifer saying, is it possible that allergies are associated with getting chronic uveitis? So we went to our data matrix, finding the terms and concepts that match to the variables that constitute chronic uveitis and juvenile arthritis and allergies and so on. The counting is the easy part. And then we first tested 4 things we already knew. So if your arthritis starts in less than 4 joints, it's called oligoarticular onset, and that increases your risk of getting uveitis. If you're positive for this test, antinuclear antibodies, it increases your risk. If you're RF factor positive, it reduces your risk, and if you have psoriasis or a history of it, it increases your risk. So this is just to build confidence that we're not seeing some random associations. So these 4 checked out the way we thought they should. And so we tested allergies and allergy medications as a surrogate for them, and yes, we see an association. So now this brings me to a fork in the road between the science and the practice of medicine. I could go down the science of medicine, do the school of medicine thing, and ask, why is it that allergies are associated? What's the underlying immunological mechanism? Can I find a drug that blocks it? And so on. Or I can go down the practice of medicine and say, what the heck? This is a question we ask at every doctor visit. Even if it's confounded, it is an association, which is real. I will open up Outlook and schedule an eye appointment for the kid who marks yes for an allergy medication. It could be that the primary care docs are misdiagnosing uveitis and giving an allergy med. Who cares? But at that point, it is simple risk stratification and triage. You don't need FDA's approval for that. So there's a lot that can be done by very simple data mining with basically counting and division that could actually prevent a kid from going blind. And I love this paper for two reasons. One, that it was actually good work, and second, the Wall Street Journal found out about it twice, 2 years apart, and wrote a story without talking to the previous reporter. So that was awesome. So this is what happens under the hood. We have data coming from Stanford, with some from Mount Sinai with a collaboration with Joel Dudley, Sutter Health System, a collaboration with Buzz Stewart, and Denmark with Henrik Sorensen. And we get coded data, which is labs, medications, ICD-9 codes, ICD-10 codes in case of Denmark. And then we get textual data from the US sources, and then we process it through 6 different text processing pipelines. And we do 6 because in my mind, text processing is pretty much a commodity now. Yes, in theory, you can do some fancy text processing to get better feature extraction from text, but 80–90% of the mileage you can just get out of the off-the-shelf system. Then we put all of these things in a relational database. We love torturing MySQL. We have about 44 schemas on one MySQL server, with most of those schemas having 3–4 tables with 4 billion or more rows. And we do joins across them. If you have enough RAM, it works just fine. And then recently we wrote a search engine on top of it, a real search engine which allows us to get millisecond responses for cohort building so that I'm not writing 3-page long SQL queries and waiting 10 minutes to get my set of patients, which is typically the biggest bottleneck for this kind of work. And then we get that patient feature matrix. We never actually materialize it on disk, and then do the predictive models, insights, or clinical studies. So that's sort of the underlying infrastructure. We spend a lot of time in this upper right-hand corner, which is called the knowledge graph, or UMLS. It's for 2 reasons. One, I trained with a group that does a lot of ontology work, and when the Knowledge System Lab was alive at Stanford, there was a lot of activity in this space. And 2, because it's actually useful. So the point here is that you can think of these drugs, disease, procedures, devices as having some connections between them. Melanoma is a kind of skin cancer. Atenolol is a kind of beta blocker. All of this prior knowledge is given to you pretty much for free by the National Library of Medicine in the form of UMLS, Unified Medical Language System. The problem is that the UMLS has 144 such graphs. So if you're interested in diseases, you have to pick from like 20 of them. And we come up with ways to find your favorite thing. Let's say this was melanoma in all the 3 different terminologies that might matter, say ICD-9, NCI Thesaurus, and SNOMED, and draw that red bag of things that means the same stuff. So myocardial infarction, I do this process, I'll get 47 different labels. And then, of course, the hierarchy, because if you're doing data mining, you don't have to be a statistician to know that having one feature is better than 1,800, which is about the reduction you get if you use RxNorm to collapse all the trade names of acetaminophen to acetaminophen. There's 1,800 trade names. So you could have an extremely sparse matrix with 1,800 columns and a couple of ones, or you could make it into one column. And then this is just metadata, which for every string, we know how often it's a noun, what's the frequency of mentions in our corpus, Mayo's corpus, in Newswire, or in Medline, what fraction of the time is it in Medline, is it a noun, how schizophrenic is that string, in the sense CELL could be a device you make a call with, it could be something that grows in a petri dish, it could be something that powers a flashlight or this laser pointer, it could be a terrorist cell, too many different semantic types. But myocardial infarction has only one semantic type. It's a disease. There's no way you could misinterpret it as a drug. So things that have only one semantic type we kind of like, and those make good features. And then all of this stuff I'll get into as we go through the talk. Okay, so concretely for the juvenile idiopathic arthritis and the uveitis, I do these 2 steps. That's what you get. You get all of the ICD-9 codes, all of the different variations. For the drugs, you get Flonase, Nezacort, Zyrtec. This one I don't even know how to say. So there's no way I would have typed it up front. So by doing it this way, your search understands medicine. That's sort of the basic idea. Okay. So once we did this, we did a couple of others around looking at safety of silastazole in treating peripheral artery disease and the risk of congestive heart failure. The last one we did was the use of androgen deprivation to treat non-metastatic prostate cancer and the risk of getting Alzheimer's. So same patient feature matrix, count, variables. And the one extra thing we did here is instead of just testing known things, which are positive or negatively associated, we tested a few things we knew for a fact are wrong, as in should have no association, either positive or negative. And these 5, we want to make sure that whatever procedure we're doing, just long division or some fancy regression, these should not signal a positive, because if they do, I know something is off. So we do that. Then we test a few known things like before. Age, yes, there's a slight signal. History of cardiovascular disease, there's a slight signal. And then the androgen deprivation, and yes, there's a strong association with Alzheimer's risk. If you're above 70, the risk is threefold. And that's what the Kaplan-Meier plot looks like. So from a faculty member perspective, this is great. This is now a perpetual paper machine. I can get a postdoc, a clinical fellow who has a question, turn the crank, 3 months later, you have a publication. But it gets boring after a while because it's kind of very generic. So we said, could we do this in a more systematic way? And the way we generalized our thinking around this is to articulate the problem as a lot of medical care being educated guesses. And the opportunity is to make decisions based on what happened to people like you. Simple idea. So 55-year-old Vietnamese woman with asthma now has hypertension. She walks in. You're the treating doctor. There's absolutely no clinical trial that will tell you which antihypertensive to use. And you don't need artificial intelligence to tell you what the goal is, to get diastolic pressure under 90. But which drug will you use? So clinical decision support that's trying to outsmart the doctor, in my personal opinion, is a waste of time. Just look at the decision support companies that have been around for the past 1 or 2 decades. None of them are worth more than 20 million. That says something. And then all I want to do is, given the data that I have for the 2 things I'm considering, I want to show a plot for time to event. So diastolic pressure under 90. This is counting. There's no way you could go wrong in that. There's no model involved. Then what associates with the outcome? Yes, you could go wrong over there. You can do bootstrap sampling of 80% of the data, do that in multiple data sets to get a sense of how consistent or reliable this is. You can borrow things from econometrics and do causal regressions to the best of your judgment, see whether this association is attributable to this drug or not. And then you show a summary of what is the underlying cohort. It would be a lot better to make decisions in this way than just taking a guess. So I view this as being able to provide an informatics consult. So just like there is radiology, there is pathology. I'm envisioning a discipline where when this happens, the treating physician can request through the EHR a consult, and about an hour later they get a fax, and I say a fax, not joking, but that is the interface of the health system, that would tell them what we can say based on similar patients. So that's what I'm really interested in doing. And those of you who would be interested in that, I would love to chat with you during the reception. So this sounds like a nice idea, a new idea. Take a guess as to when was the first time somebody did this. Take a random guess. Well, you can't. You already know the answer. 70s. So this is a prognosticogram from Duke University in 1975 to create, get an index case. Patient A has these characteristics. They found a subgroup of 18 patients. Now they're just tabulating, just counting, and then they're doing the Kaplan-Meier curve as a prognostic tabulation. If you treat this person with medicines or you do surgery, outcome is alive or dead. So pretty basic. But I mean, survival and cost are the only two real outcomes in healthcare. Everything else is some combination of those. So we said, all right, it's not a new idea. Didn't work in that decade because EHR's adoption was in the low single digits. Thanks to the Affordable Care Act and the ARA funding and high tech and all of that, EHR adoption is above 85%. So we said, all right, could we do this? So here's an example. Asian or black men of age 40 to 90 who had a heartburn and were given a proton pump inhibitor within a month to 4 years and who had a heart attack within 1 to 3 years after that. Some of you here have some familiarity with mining EHR data. What would it take to build this set of patients? Any takers? Just guess. Come on, you can take a guess. Yeah. No. How many minutes, days, hours to get these? 0.47 seconds. So we have this search engine working at Stanford, and in 3 lines. So that is the state of affairs in healthcare. You ask most people, you will get the answer we just got. And it is true at most other places besides Stanford that it will take you 2 to 3 months, or you might not even be able to do it because you just don't have access to that information. 0.47 seconds. What? Yeah, this is unfortunately just for Stanford right now. Okay, so what we're looking at here, blue is the reference population, red is the cohort. I wanted men, 100% are men, good. I wanted Asians and blacks, all of them are good. This is telling me the duration of, the number of encounters I have, how much data I have on them. I asked for a lot of coverage, so yes, all of these graphs are in the right way. They're all between 40 and 90, and so on. Then I can download this data set, these 26 patients, and then analyze them whichever way I want. So this is nice. This works at Stanford, but Stanford is a small hospital. My data set is about 2 million patients total, and with my collaborations, it goes up to 8 million patients. But that's still not enough. So I'm a part of this group called Odyssey, Observational Health, Data Science, and Informatics, where everyone has agreed to put data into one common data format. We're not using the search engine yet, so I can't do that in 0.47 seconds. You still have to write 3-page long SQL queries. But if you suffer through that and you write the SQL queries, we have a paper coming out, which I'll walk you through in PNAS, where we looked at the treatment pathways of diabetes, hypertension, and depression. So there's guidelines on how you treat diabetes, there's guidelines on how you treat hypertension and depression, but then those things exist in PDFs and publications of professional societies. What happens in real life? So what we're looking at is a sunburst plot for diabetes. The inner circle is the first line of drugs people get. The second one is the second line of drugs, third, fourth, fifth. We went all the way to 20. And the color tells you what drug it is. So the guidelines for diabetes treatment say you should start with metformin, and yes, that is what people are doing. And then they say if your glycosylated hemoglobin is not controlled in 90 days, use a second-line drug. So here's a second-line drug, but they don't tell you which one. Just say pick one. So the first study we did is 9 sites, descriptive, worldwide, 250 million patients, describing what happens. We're not making any recommendations yet. So this is the leftmost part. What is happening? Turns out that for hypertension actually, a large fraction of patients are on drug sequences that are unique. 20% of patients. It's kind of shocking to us. So that's just coming out in PNAS. It's led by a group at Columbia, by George Herbsack, and there's a few other people, John Duke and Patrick Ryan. But if you just search for OHDSI, you'll find this group of people. So then we said, okay, fine, now we know what's happening, but is it good? I mean, yes, people start with metformin, and some fraction of them end up with glipizide, but is that a good choice? So now we need to look at outcomes. So if you start on metformin and stay on metformin, this is now just Stanford data, so not 250 million patients, versus you start on glipizide and you stay on glipizide, so you're either here or in this 4.3252%. The rate at which your glycosylated hemoglobin comes down is about the same. So if the two drugs work for you, life is good. But if you need glipizide, so you start with metformin and you need to go on to glipizide, life is not good for you because your glycosylated hemoglobin does not come down as fast, which is what the guideline says. If this happens, add glipizide. We can predict this is going to happen on day one before the 90-day cutoff. And we can find diabetics defined in this way, ICD-9 code of 250 and metformin within a week to a month who have high A1C 1 to 2 months after treatment, 0.46 seconds, 183 patients. Then I can take these individuals and ask, okay, so now these are the guys in whom it wasn't coming down that fast. Some people got glipizide, 32 of them. Some of them got pioglitazone. Some of them got sitagliptin. Which one is better? Turns out that at all cutoffs of hemoglobin A1C, sitagliptin added to metformin rules. The American Diabetes Association probably doesn't know this yet. So last example, patients with cryptogenic stroke. That's ugly expression over here, that you have these two things and not have all of these things. You must be an inpatient, not have thyroid disease, no heart valve stuff, no disease of the mitral valve, no rheumatic heart disease, yada, yada. It's basically a stroke of unknown origin. That's cryptogenic stroke. Typically, these people get discharged with aspirin. And then about 10 to 15% of them will end up with having being diagnosed with atrial fibrillation after the discharge. And so we say those who had a cryptogenic stroke and then got diagnosed with atrial fibrillation within 1 to 5 years, and we find these about 200 patients. These are people we should be discharging on anticoagulation and not just on aspirin. So right now we are in the process of saying, okay, for these 199 patients, do we know what known risk factors of atrial fibrillation did they already have? Because if they do, then we shouldn't be discharging them just with aspirin. Okay, so the outline of a future informatics consult is, first I just want to give a descriptive summary. What happened after treatment? Then get into making recommendations. What treatment choices are typically made, given prior history? What are the typical outcomes? So I've shown you examples of first two bullet points as a working system. We're working on how to estimate the effect of treatment choice X on Y. That's relatively tractable. And then the hardest problem is you haven't given this thing X to the person. Can you still estimate the probability of Y? In estimating the counterfactual, whoever solves this, of course, gets a Nobel Prize, but it is a hard problem to solve. So the way I think this will be used is patient walks in, you have a guideline, of course go use it, otherwise use this thing we're calling a green button or an informatics consult. We will build a cohort of similar patients and give you practice-based evidence, otherwise go ahead and keep doing what you were going to do. And as a byproduct, we can collect a priority list of clinical situations and then queue them up for randomization or point of care, a point of care randomization at a later date, where we're not able to say anything, but if the question is being asked enough number of times, that's where you should be doing RCTs. All right, so there's lots of problems to solve, electronic phenotyping being one of them. How do you know the patient has whatever condition, diabetes or hypertension? Right now we're writing those ugly expressions. I showed you one for cryptogenic stroke. How do I really summarize a set of similar patients? How am I going to find similar patients? What's an optimal cohort for estimating treatment effects? And then how do we actually plug in the last mile of bridging into the health system? So these are problems that we focus on quite a bit. Right, so I'll stop here for a second. I have about 5 minutes left. I could go deep into electronic phenotyping or give you examples of the other two buckets, the insights and the predictive modeling. So who would want to go deep? Who would want to see the other two examples? The other two examples, just raise your hand if you want to see other two examples. All right, and go deep here. One or two, right. So I'm going to show other examples. Majority vote. Okay, so the further slides there were all about the problems I need to solve in order to get the informatics consult working. The other two buckets, on the inside side, we sort of stumbled into this at some level. We were looking at deep vein thrombosis rates after surgery, joint surgery. And people typically look at 30-day DVT rates. And I happened to ask a question like, why 30 days? I didn't get a straight answer from anybody. Why 30 days? And so we made this histogram. This is the time between surgery and a DVT mention, and in 10-day increments. So 30 days is right about here. And then there's this bump around 120 days, another bump around 200 days, and then about a year out. If you were reporting this as a HEDIS measure, your hospital could go from being in the top 10 to being the bottom 90. So we're working on ways of extracting the characteristics that count patients in the numerator and the denominator for a whole bunch of quality reporting measures, PQRS measures, physician quality reporting system. Here's another one, urinary incontinence after prostate surgery. The left is what you get if you count using ICD-9 codes. This is what you get if you count using text mining as well. And when a man has prostate cancer, there are only two questions. Are they going to leak and will they be impotent? And if you have to choose between robotic surgery and open prostatectomy, this is a rate that you really want to know. And in our first pass analysis, the rates don't seem that different between open prostatectomy and robotic surgery. If you're paying out of pocket on a high deductible plan, that piece of information is worth about $10,000 to $15,000 to you. All right, so I gave the example of the true reference ranges and how do you learn them. So this is hemoglobin. Yellow distribution is the raw values as is from our data warehouse, about 130 million lab tests. Then what we're doing is we're asking what associates with being members in this left and right tail of this yellow distribution. And whenever we find those diseases, we remove all patients and all measurements of those patients from the distribution. And we keep doing that iteratively till we find nothing that is specifically associated with being in the extreme 5 centile or 95 centile of the distribution. So when we stop, this reddish distribution, pink distribution is what we stop at. That is our learned range of hemoglobin. And okay, how do we know we got it right? We look at the cutoff here and look at the 5% cutoff here, and we ask what fraction of patients below that actually get an iron supplement. And the cutoffs that we learn have a positive predictive value of 90%. So that's how we know we got it right. Here's another example. We're looking at the bias in a point-of-care glucometer and a reference lab. So in an ICU, you're not supposed to be using point-of-care glucometers to measure glucose, but everybody does it. So we said, okay, how bad is that? And can we learn that from the data? So what we're looking at here is the absolute glucose measurement. What we're looking at here is the difference in the measurement you would get from a point-of-care glucometer versus a lab measurement, a central lab measurement. In a very large data warehouse, it does happen that somebody takes a point-of-care measurement, and for whatever reason, within 5 minutes, they do a blood draw and measure glucose again. Don't ask me why. So that's this green dots. I'm not going to go into the blue one. This green detect, which is data mining EMRs to evaluate coincident testing. And these dashed lines are those cutoffs at which what you do would be different. So these people, all the green dots over here, the bias in the point-of-care measurement is high enough that you would act differently than if you had gotten the central lab measurement. So that's bad. Being out of this cone is bad. Being in the cone is fine. So it turns out that in about 10% of the 9.5% of the cases, your bias is high enough that you would act differently. So it's not that bad. 90% of the time, you're still making the right judgment by using a point-of-care glucometer for glucose testing. So this is also an example of how just by looking at a data warehouse, you can monitor which glucometer is out of calibration on what floor of the hospital. Okay. So last example. I'll take about 60 seconds of the Q&A. I told you about prediction versus classification. So think about the timeline of a patient's medical record. Stuff happens when you come to the hospital. Let's say something happened, you come, and there's a whole bunch of codes getting assigned. All of that happens after X. So if you do analysis here, you're doing classification. If you do it before, you're doing prediction. So true prediction happens before something happens. And the trick is, what will be the source of features and the choice of features that you will use in order to predict this red arrow before it happens? So the example I'll show you is predicting delayed healing wounds. Turns out that diabetic foot care is an interesting industry, or just wound care in general, that hospitals are not good at making money off of it. So they outsource it to, subcontract it to a third-party provider who rents a room in your facility, and then they're paid on a pass-through basis. One patient, here, $100, $50, I don't know the payment model, but it's fixed per patient. And then it's their job to get the foot healed. And so if the foot doesn't heal in 16 weeks, they end up losing money. So this company, Healogics, is one of the largest provider of wound care services in the country. So we collaborated with them. We got data from 68 centers in 26 states on 60,000 people. 180,000 wounds. We know the type, we know location, and for each wound we know 28 different characteristics, how big, is it red, and so on. And the goal is that on day one, we want to be able to say this wound is going to go bad, and we have data spanning 5 years, about 1.2 million measurements, give or take. We did a lot of fancy stuff, everything in the machine learning textbook, gradient boosted models, stacking, ensembles, blah, blah, blah. Bottom line, there's something called non-stationarity of the data, and logistic regression still rules, at least in healthcare. And I could give you an hour-long dissection on why you shouldn't just throw deep neural nets at stuff and call it a night. It does help to understand how the data is being collected and so on. At the end of the day, we have a good discrimination of 0.827, works across all 18 different wound types. And the calibration is also good. And this is really important because if I say that there's a 90% chance that a wound is not going to heal, and I say that for 100 wounds, 90 of them actually don't heal. So this is something you can base a decision on. It's clinically usable performance. Because you can have great classification and completely out of whack calibration and still get good classification because you're on the correct side of the threshold. But you can't make clinical decisions based on that. So that's one example of predictive modeling. I don't have time to go into the other ones, but I think that gives you a good flavor of what things are. And here are what I think are the big problems worth solving, or fruitful areas of activity. Risk stratification, cost, latent disease decompensation. Personalizing evidence, what's the risk for me? Insights into disease progression. Passive data collection. There's everyone collecting data. No one knows really what to do with it. And practice management. So on the passive data collection side, by looking at people's Fitbits, could you predict who's going to benefit or not benefit from a joint replacement? That would be useful. In predicting missed appointments, costs stand for something like $40 billion a year, medication adherence, and so on. And I will close with acknowledgments. These are the people in my team that make all of this cool stuff happen. A lot of alums and funding from a ton of different sources to keep it all going. So I'll stop here.